Okay, so the next area that we're going to look at is pleural effusions, and this is when there is a small amount of fluid in the lungs, and again, it's usually the lower lobes. That's the dependent area. That's where the fluid will go. And so if it's a small enough an effusion, then the body will reabsorb it over time. However, if it is large enough, then the physician may order what's called a thoracentesis, which we just discussed a minute ago, where they go in and tap the fluid, so that will remove it and provide relief for the patient. And then it allows more room for the lung to expand, and the patient will be able to breathe better right away. If an infusion is large enough, then we will end up having to put a chest tube in that will provide continuous drainage, because some of the effusions are really large and they continue to produce more and more fluid. So, but again, it depends on where the patient is on that spectrum, whether it's just a small effusion the body will reabsorb with time, or whether it's in the middle, which is like a medium effusion where the patient's physician will order a thoracentesis to go in there and tap and remove the fluid, or if it's too large to tap or it continues to build up even after being tapped, then we'll end up putting a chest tube in to provide continuous drainage and to help relieve that area so the patient can breathe easier. Atelectasis is when the lung tissue collapses, blocking part of the airway and the lung. It's not unusual to see this happen after surgery when a patient's been lying flat for several hours. Then they're at a higher risk for getting an atelectasis to happen, because patients tend to come out of surgery and they're breathing. They're hypoventilating. They're not wanting to breathe deeply and cough. We also see this happen with some of our emphysema patients because they are coughing so much, or patients who have tumors in their lungs, causing the coughing to be so extreme that it will cause actually the lung tissue to collapse. Many times what will happen is this lung tissue will collapse upon itself, and when it does, it'll trap mucus in there, and then that will lead to pneumonia because this mucus contains bacteria in it, and again, it's in this really hot, moist area, and that's just the perfect breeding ground for bacteria. So it'll end up causing a bacterial pneumonia situation where the patient will need to take an additional antibiotic to kill the pneumonia bacteria. So treatment for these patients that have atelectasis is, again, ventilation. And we usually will do mechanical ventilation. So coughing and deep breathing. The nurse will come in and do chest therapy. Anything that will help the patient cough and deep breathe and re-expand that lung so that the lung will remain fully extended, and therefore the patient will get relief from that. All right, next topic is pneumothorax, or a collapsed lung. So literally this is a collection of air in the pleural space causing that lung to collapse. And we see patients who come in with traumas, severe coughing events, or they can even happen spontaneously where they've caused their lung to collapse. They'll be short of breath. They're very anxious. They are very scared because they're not able to get a really deep breath. So again, sorry about that, we got cut off. So again, they will be short of breath, anxious, tachycardic. They'll be having pleural pain. You will, when you do your assessment and you're comparing the left side to the right side, you will see an asymmetrical chest wall expansion. One side, that the impacted side, will be caved in. You'll hear decreased breath sounds on that affected side. So Diagnosing it is all of those symptoms we just discussed, but a affirmative diagnosis, or confirmative, I should say, is a chest x-ray. So we do the chest x-ray, get those back, and it'll actually show the pneumothorax there. And once we get the chest x-rays back, then the order from the physician will come to treat the patient, and that is usually done with a chest tube, because the chest tubes relieve the pressure on the lung and it allows it to re-expand. So put a chest tube in that will take out the air, any kind of fluid, and it will allow the lung to re-expand. Once the lung is fully extended and expanded, then the chest tube can be pulled. Other causes for a pneumothorax is a rupture or blood, like from COPD. We can have trauma to that area. Say if something, we had a patient who ran a light and ended up hitting a one of those fences that has the steel poles at the top. One of those poles went through his chest and it ended up collapsing his lung. If there's any type of trauma from the outside to the inside, from the outside of the body to the inside, then you'll literally hear a sucking sound when the patient takes a breath in and out, where that trauma is at. So be aware of that. And then, of course, we're always going to be worried about secondary infections, right, from these traumas. So we need to be aware of that as well, and treat accordingly. Next on the list is pulmonary embolism. That is a blood clot, fat, air, or amniotic fluid that is literally obstructing the pulmonary artery, or it branches of the pulmonary artery. We have people who are at a higher risk, so post-op patients definitely at a higher risk. That's why we do all of our interventions, like putting on the SCDs, getting them up as soon as we can to walk around, putting them on blood thinners, etc. We also have additional at-risk people for PEs, would include overweight patients, patients who smoke, patients who have a history of blood clots, and patients who have who are at a higher age. So the older you are, the higher risk you are. Abnormal clotting disorder. So if there's a clotting disorder in the family, either you clot too much or you over clotting. So signs and symptoms of a pulmonary embolist include sudden shortness of breath. It's not something that happens gradually over time. This is something quick. As soon as that DVT breaks off and goes to the lung, the patient is suddenly unable to breathe. They complain of chest pain. That's worse when they breathe in. Their heart rate shoots through the roof. They're sweating, they're anxious, and they may even pass out because they're so anxious from the pain and what's going on in their body. They know that something isn't right. They even say that many times. So again, you will see the affect of it is the SpO2 will drop and continue to drop. So the saturation of oxygenation drops. Again, how we prevent PEs is that we put those compression stockings on, get the patient up after surgery, put them on anticoagulants like heparin or Lovenox. If we have a stable PE, a physician may decide to put the patient on bed rest, and the only time a patient will be given the go ahead to be on bed rest and not get up and walk around is when there is a PE present and active in the lung. Then what they'll do is they'll have them be on bed rest, so that will give the body time to reabsorb that pulmonary embolism that exists in there. If it is unstable and it is life-threatening to the patient, then they may opt to go in and surgically remove the pulmonary embolist, and what they'll do is they'll do an embolectomy. Or another option is if it's in an area of the body that's stable for now, but there's a risk that it might move and potentially cause loss of life, and they'll maybe go in and put a vena cava filter or vena cava filter in there to protect the patient. Next, we're going to look at pneumonia, and this is literally inflammation in the lungs caused by a bacterial or viral infection. And so the air sacs in the lungs fill with pus and cause, obviously, a challenge for the patient to breathe because the area is now taken up with fluid of pus instead of being open to have the exchange of air happen at the end there. So patients will be symptomatic, will be coughing, have fever, chills, they'll be tachycardic, tachypnic, short of breath. They'll have pleural pain. They will be malaise, fatigued. They'll definitely have a decrease in the breath sounds when you listen with your stethoscope. There'll be like a consolidation, or you won't be able to hear anything because it'll be literally filled with fluid. And they may, if it's been going on for a while, they may be in respiratory distress. So we need to be aware of that. Again, it's obstruction of the bronchioles, and therefore there's the inability to have that gas exchange where the O2 is taken in and the CO2 is breathed out. Again, the productive cough could include blood or rusty sputum, yellow blood streak sputum sometimes, and the doctor will again take a sample of this and see if it is bacterial and what antibiotics will fight off or beat that bacterial infection. So some opportunistic infections that are seen many times with patients who have pneumonia include pneumocystitis, Carini pneumonia, Mycobacterium avium, complex MAC. These are all on your PowerPoint. On the PowerPoint slide in front of you. And then one other one is the Girovecchi, Giroveci, Girovecchi pneumonia. It's a very opportunistic infection as well that likes to grab hold when a patient's compromised. So we will treat the patient with fluids, rest, antibiotics, and if it's viral, then we won't include the antibiotics. Sometimes the physician, if it's viral, will give an antiviral to help, but many times they'll just treat the symptoms and make the patient comfortable from that. And the last three topics we have are emphysema, chronic bronchitis, and asthma. So chronic obstructive pulmonary disease is a progressive, irreversible condition, and we have emphysema and chronic bronchitis are the two that fall under COPD that we're looking at this block. So with COPD or chronic bronchitis, you literally have thick, sticky mucus that blocks up the airways and therefore makes it very, very difficult to breathe. You have inflammation and swelling of the airways due to this thick, sticky mucus. And then with emphysema, on the other hand, there is the actual alveoli is damaged. And so you have like patches of bad alveoli. So air exchanging becomes very difficult with this damaged alveoli. I mean, the air gets trapped in there, literally causing CO2 buildup. The other thing we're going to look at this block is asthma. And we'll talk last about that one. So we're going to go ahead and stop here, and then I'll restart with the next one. Thank you.